Join me now. I'm pleased to introduce Dr. Mark Cameron. He's an immunologist at Case Western University in Cleveland, Ohio. Mark, thanks very much for taking the time today.
Thanks for having me.
And I appreciate you, jumping on. Just as I mentioned, Mark is a Canadian who's gone over to the dark side, across the border to the U.S. to help out on that side. Now, Mark, the reason we are talking to you today is not only your extensive knowledge in immunology, but you were actually boots on the ground during the SARS epidemic in Toronto. So first of all, I just wanted to chat quickly about that, and what are some of the lessons learned from that experience that can help with this current pandemic?
Right. So I was part of a rapid research response centered out of Toronto General Hospital in 2003 during the SARS outbreak there. There's a lot of familiarity for how I felt then versus how I feel now. The unknown of a new virus affecting a community, the unknown of how best to block transmission and to break the viruses back so that we can get back to some sense of normalcy. Toronto was the only city affected outside of Southeast Asia in 2003. So the impact of a coronavirus pandemic to Toronto was very unique and was very unique to us, and something that I don't think a lot of cities in North America feel right now with COVID-19. The lessons we learned at that time were very poignant and very urgent. Toronto had no rule book back then in how to deal with an epidemic. So putting protective measures in place, doing social distance, and declaring a state of emergency was part of Toronto's plan. And that massive public health directive and response controlled the SARS infection in 2003. Now, 17 years ago, we were just about to relieve some of those measures. And Ontario was just about to relieve its state of emergency. And once that happened, I believe it was May 17th, 2003, Toronto experienced a second wave based largely out of hospitals and long-term care facilities. And I remember that being a crushing blow to Toronto. We had just got to the other side of the initial epidemic, and then we had to go through a second wave. And the second wave lasted just as long as the first. Now, how does that relate to now with COVID-19? Well, we are just at that stage again, where we are thinking about relieving some of those health measures. So those are my concerns right now.
Yeah, I'm sure you're experiencing a bit of scary deja vu here on a much wider scale, because I know on your side of the border, things are opening up even faster than they are here. And the U.S. has become the epicenter of the problem, right? So how does it feel to know that, it clearly is opening up way too early?
Right. I feel optimistic in terms of planning a return to some sense of normalcy. However, the US and Canada are still at the peak of their curves. So Canada is still adding cases every day to the case count, and it's still a linear part of our curve. We have slowed down the number of new cases every day, but that is still at its peak. So it's a little strange for me to be considering rapid removal of some of these more dramatic public health measures and get back to some sense of normalcy. It seems more difficult to plan that and to have some of those measures come off than just to wait a little longer until we are clearly down the other side of this pandemic curve.
Mark, before we had this interview, we talked a bit about the Spanish flu pandemic that has a lot of parallels to this situation now. And one of them was that they did ease these restrictions just ahead of the summer. And of course, that changed, in the fall. It came back in an almost worse way. The second wave was much worse than the first. So everyone's wondering, is that what we're going to see at this point?
So almost everybody agrees that we are due for a second wave this fall of COVID-19. And that's because there are many people who are asymptomatic with COVID-19, meaning there are people that are infected with the virus that don't know they are infected. Back in 1918, during the Spanish flu, the backdrop of that pandemic was travel due to World War I. So the virus was spreading worldwide on the backs of travel and on the backs of a period of time where obviously testing and tracing of infections around the world were at its infancy. However, at the time, doctors knew to wear masks, to not congregate in large numbers of people. They knew the basics of blocking transmission even at that time. And those measures we're using also with COVID-19, and they are working. Social distancing, wearing face coverings in public. There are a lot in common between that era and now. Obviously, there's better medical approaches. Obviously, we have made very quick gains on rolling out vaccines, at least to the first phase of human trials. But remember, that was H1N1 influenza that caused Spanish flu. We had an H1N1 influenza swine flu in 2009 that emerged in the late spring and summer at North America and spread worldwide. Now, that was part of a modern era of tracking and tracing and treatment. And because it was influenza, and there is a engine every year that produces a different influenza vaccine, we had a vaccine for H1N1 swine flu by the next fall, which was coordinate with a second wave of H1N1 swine flu in North America. And the vaccine availability there at the same time helped us break the chain and prevent third and fourth waves largely from occurring. The H1N1 swine flu epidemic lasted about 20 months in North America and around the world. Now, if we look at COVID-19, it is another virus that has spread worldwide. It has a lot of foothold at various countries around the world. And it's spreading very easily because it either produces a mild illness in most people, or it's asymptomatic. People don't know they're infected as well. So people are pretty sure that there will be another wave in the fall, if not right now, if we release our precautions too early. And that's something we have to plan for and deal with. What we need to do is make sure there's enough time for the science to catch up here, either with new treatments to treat patients that have severe forms of COVID-19, or to ready the vaccine in time to break the chain outside of it running wild amongst us while we're doing all of these dramatic public health measures.
So, Mark, let's talk about a vaccine. So, original projections around March were 18 months. Your own president, Donald Trump, has asked for a warp speed vaccine, which, I understand was about a year now. So tell me, what are the projections now? How soon could we see a vaccine hit the general public?
So warp speed vaccine development has actually occurred right now, although those are the first few phases. Because of our experience with SARS in 2003 and H1N1 swine flu 10 years ago, and also MERS, Middle East Respiratory Syndrome, another coronavirus from a number of years ago, the vaccine development phase hit the ground running. So warp speed was quite appropriate for the phase we're in right now. Right now, there are hundreds of vaccine candidates worldwide that will move to various stages of testing. In the US, there are 8 vaccines already in clinical trials. Now, that is the first phase of rolling out a vaccine, where they are giving the vaccine to small groups of healthy individuals. That's just phase 1. And what they're looking at in phase 1 is the safety of the vaccine in general and whether an immune response to COVID-19 is adequately generated. The next phases, phase 2 and phase 3, is bringing the vaccine out to larger and larger groups of people as a clinical trial. Phase 3 is the largest, where thousands of individuals are vaccinated, including the people that will need the vaccine the most, i.e. with COVID-19, the elderly. And then looking at that stage further at safety, making sure there aren't any adverse events that occur in the vaccinees. And then the efficacy. Is this vaccine, or this particular vaccine, because there will probably be several candidates, effective at protecting the population when they're exposed? The second and third stages of that clinical trial process to get to a vaccine that can be selected and rolled out to the general public takes a long time. What I hope for is, if we're talking in a year now, that the vaccines that kind of rose to the top during the development as the safest and most effective are at that stage 3 clinical trial. And then what has to happen then is, if it's effective, if it's safe, it has to be manufactured and rolled out as a vaccine to the general population. Now, that is a relatively short amount of time over the next year, year and a half to actually do that. Everything would have to fall in place. The vaccine would have to be very effective in all of the people that are treated. What I'm hoping for, and I think it's a reasonable expectation, is that the SARS-CoV-2 or the COVID-19 vaccine is available for the 2021 autumn start of the cold and flu season. And I think that is a reasonable goal. But warp speed really is a term that right now is describing the science the world over to identify a number of different vaccine candidates that can be pushed forward in parallel, which is going to be a very costly process to pick and choose the most effective way of vaccinating people.
Mark, my last question for you is about mutations and reinfection. Now, there's been some discussion that, and some reports that this is not happening, it could be happening. I'm curious, what is the realism of a mutation happening? How long would that take? And how does that how does that play against the vaccine process?
Right, so every virus has a family tree. And the COVID-19 virus is no different. As it emerged from Southeast Asia and spread around the world, scientists have been sequencing it and watching for mutations. And they've identified small little changes as it has spread around the world. So the SARS-CoV-2 that you might find in Toronto or Cleveland here may be slightly different from the virus as it emerged in Wuhan, China, or affected Italy. Now, so far, the virus has been quite stable, and coronaviruses typically are, unlike influenza viruses, which change on us almost every year. And the mutations have been quite small. Now, I've seen studies that have shown that there has been a mutation or two that has made the virus a little more dominant, a little more strong in infected people. And I have seen studies where mutations have impacted the virus's ability to infect and survive. So there's a balancing act there. The good news is, so far, the coronavirus appears to be stable, and the mutations that have happened have not had an impact to the level where we would worry about the vaccines we are developing today not being effective when they do get developed and rolled out. So far, the SARS-CoV-2 virus has been stable, and that's a good thing for a good thing for vaccine development.
All right. Dr. Mark Cameron, thank you so much for taking the time. Really appreciate it. I hope you stay healthy and stay safe.
You too. Thank you very, very much.